preservation of the gonads in patients undergoing chemo and radiotherapy.
Thank you very much, Madhuri. So good morning, everyone. So first of all, I'd like to thanks to Professor Osgur Oktam for inviting me, Professor Nalini, and also Professor Nao Suzuki for having us in this very interesting session. So I'd like to continue from Professor Osgur Oktam already explained very well. So we know that fertility observation is a branch of the reproductive medicines that prevents the couples from losing their reproductive ability to conceive for their own genetics. And then this is also already mentioned by Professor Osgur that at least 8% of cancer was found in the women less than 40 years old. So that's why this is our challenge, how to keep the chance to having their children even after the chemotherapy or radiotherapy. And then this is the 5-year survival rate, already mentioned as well by Professor Osgur, that more than 90% of survival rate. Number one is melanoma, following by breast cancer, and also endometrial cancer. And then what is our problems? We know that both of chemotherapy and radiotherapy will induce DNA damage. And then the side effect of DNA damage both by chemotherapy and radiotherapy will leading to POI or also infertility. The molecular mechanism of DNA damage and interaction between DNA damage response and signaling pathway connected to the activation of primordial follicles. If you look these figures, when DNA damage activated CABL antibody and then high level of CABL will activate TAP63 that will mediate cell death. And then TAP63 is responsible in using transcription of pro-apoptosis family members, including the PUMA and then NOXA, and then will leading with apoptosis process. And on the other hand, also that TAP63 responsible for inducing activating P10 and PI3K follicle activation pathway by increasing P10 level, thereby reducing PIP3 mediated KT phosphorylation and inhibiting phosphorylation. Both of PI3K, P10, AKT pathway, FOXO3, and hyposignaling pathway is the important primary regulators of primordial follicle activations. We can see here in further details in the preganose cells kit ligands, and then it will activate in PI3K, PIP3, and then P10 will AKT pathway with down-regulated FOXO3, and then together with mTORC will activate primordial follicle activations. And then on the other hand, the hyposignaling pathway, very important, induced by internal stress or ovarian tissue fragmentations, and also the same will activate primordial follicle activation through YAP and TPAZ. This is, for example, cyclophosphamide-induced dormant follicle activation and loss, as Professor Osgur already mentioned as well. The primordial follicle actually underbalance regulation by the PI3K, P10, and AKT pathway, and suppressive factors produced by growing follicles ensure the vast majority of primordial follicles are maintained in the state of dormancy. And what is happened when cyclophosphamide exposed? There will be upregulating PI3K, P10, AKT follicle pathway, and causing growing follicles to undergo apoptosis, and reducing the secretion of inhibitory factors that are responsible for maintaining dormancy in the primordial follicle state. So that's why combination of inhibitor for both pathway may be able to protect the ovarian reserve from genotoxic stressors more effectively. Concomitant firing of both the follicular activation pathway and DNA damage response. If we can see here, this is most of the drugs that's still in experimental. Professor Osgood already mentioned as well. This is for inhibiting DNA damage response. This is for inhibiting AKT and FOXO3 activation pathway. On the other hand, do cancer therapies damage the uterus and compromise infertility? So we know that uterine also is very important for fertility. And then even in the prepubertal girls, the uterus is stunted and resistant to HRT, while in post-puberty females, it's increasing in volume and action and functions. Menstruation may return, able to conceive naturally following radiotherapy in prepubertal females. But cancer patients are experiencing higher risk for early pregnancy loss and complications, suggests that cancer therapy-induced damage contributes to infertility. And this is the impact of chemotherapy and radiotherapy on the uterus. We can see their impact on structural, pregnancy and birth outcome, both of chemotherapy and also radiotherapy, with lowering pregnancy rates and higher incidence of miscarriage, including preterm birth, low birth weight, and small for gestational age. This is also evidence of uterine damage in response to cancer therapy. Both of chemotherapy and radiotherapy will damage the uterus. And then this is the radiation. Yeah, also with dose approximately 20 until 40 gray may lead to endometrial atrophy and impaired endometrial response to the sex steroid. Alkylating agent in systemic chemotherapy will promote epithelial atrophy. And this is radiation therapy-induced damage. The ovary are highly susceptible to radiation damage, and ovarian reserve are non-renewable. And then also pregnancy outcomes after radiotherapy. And this is questions primary follicle are more resistant to radiation compared to large maturing follicles. Then factor affecting the extent of damage, age of patients, ovarian reserve, combination therapy, immediate volume, total radiation use, fractionation schedule. This is, for example, MRI show a decrease in the cervical length after radiotherapy. So how to protect the gonads from radiotherapy? This is the protective strategies. There's novel radiation beam arrangements, modified fractionable schedule, 3D conformational radiation therapy, intensity modulated radiation therapy, lid pelvic shield, and surgical oophorexic. And then the main principle of pharmaceutical approach in radiotherapy is protection and mitigation, because a germ cell depletion to the radiation would be irreversible. Showing promising result in animal model is sphingosine monophosphate, tamoxifen and growth hormone enhancing IGF-1 expressions, inhibit apoptosis due to radiations, and reducing free radicals by amifostine. Treatment for radiation-induced fibrosis is, for example, copper and zinc peroxide dismutase, manganese peroxide dismutase, or combination, or pentoxifilin. This is the damage because of chemotherapy induced in the uterus. And then this is post treatment for chemo-radiotherapy management. Yeah, in the extreme way, of course, uterine transplantation is needed. This is the damaging effects of chemotherapy drugs on the ovary, and then potential protectants against the damage, at least because the damage has happened because of prenatal loss of gonia, direct loss of primordial follicles, accelerated primordial follicle activation, stromal damage, and damage to the vasculature. So that's why many drugs that trying to protect the chemotherapy effect to the gonads during the chemotherapy, but most of them is still experimental. You see, this one for inhibiting direct loss of primordial follicles. This is inhibiting accelerated primordial follicles, and then this one also reduce drug delivery to the ovary, and then also this one's preventing damage to the vasculature in the ovary. If you look this one, this anti-apoptosis, that prevention of follicle activation as protective agent AS101, AMH is mentioned by Professor Osgood before. Maybe a combinant AMH right now people trying to well establish. anti-apoptosis, imatinib, sphingosine monophosphate, vascular effect, GCSF, transport block, bortezomib, and upregulation MDR1, and nanoencapsulation. It's very important to protecting the gonad from the damage from the chemotherapy. And then the use of agent chemotherapy induced ovarian damage during treatment has significant advantages for fertility frustrations that's suitable for all life stages and age, and then it prevents infertility, POI, endocrine-related effect. This is so many agents for protecting ovary from chemotherapy-induced damage, but most likely, again, it's still experimental in the animal model mouse. This is, for example, AS101, ceramide 1 phosphate, and then we have here ghrelin, imatinib, melatonin, still all in the use in mice. And then we can see here the use in human is sphingosine monophosphate and tamoxifen. It's for the direct loss, inhibiting direct loss for primary follicles, both of the sphingosine monophosphate and tamoxifen. In the mice, here you can see S101, even together with cyclophosphamide, together with S101, will keep the follicles and then keep the mouse to still have live birth. The next is very interesting, the use of PRP. Might be it is promising because protective effect of PRP for in vitro fertilization of rats with ovarian failure induced by cyclophosphamide, showing the promising result. This is our study in animal model. We developed the mice with primary ovarian insufficiency by exposing them with cisplatin for 1 week and 3 weeks. And then this one is CRM phase after 1 week, after 3 weeks. Then estradiol declining, FSH increasing, and then the number of follicles decline. And then after we expose after the mice become POI, we inject the PRP injection into subperitoneal mice. And then after doing PRP injection, this one we can see the serum is getting higher. And then FSH is decline after PRP injection. And then this one is estradiol also increasing after PRP injections. And we are trying to see how the correlation between PRP injections with the increasing estradiol and declining of FSH and increasing AMH. We are trying to see that in the FOXO3 that is very relevant with activated primary follicle and DDX4 with Gonads stem cells. And then after injecting the PRP in this is the 3 weeks mice, they're increasing the FOXO3, also the 5 weeks mice, this is increasing, also the DDX4, this is increasing. This is the expression of DDX4 in the mice models after we do the PRP injection, this is increasing. So that's why might be this looks promising, the use of PRP for protecting gonad while the patients are receiving the chemotherapy. And the last is about DNS analogs. Of course, it's still a controversial issue, and including the ASCO guidelines. Even the many evidence also see that the DNS analog inhibited rapid cellular turnover in the growing follicles. So that's why it might be useful in the lowering gonadopathy in the female. So this I'm come to my last slide, that new medicine is very important to improve the outcome of cancer treatment as measured by 5-year survival rate. And then this is the chemotherapy. We know that decreasing ovarian reserve. This is sphingosine monophosphate and ceramide antagonist. It will negatively regulate apoptosis. This is given 2 hours before radiations, and this agonist preserves fertility by reducing sub-ovarian blood flow and suppressing granulosa cell growth. So as the take-home messages, number 1, we know that cancer therapy, both in the form of chemotherapy and radiotherapy, contributes to infertility or even POI. And then below 40 years old, risk of permanent chemotherapy induced ovarian function up to 20%. And the oocyte, because it's most likely dividing gonadal cells is the main target of chemotherapeutic agent. Radiotherapy causes similar damage compared with chemotherapy, in which the main principle is of the approach are protective and mitigation. This is very important, protective and mitigations. And there are several agents protecting the chemotherapy-induced ovarian damage, one of which is using generous agonist, even still very controversial issue. And the last, the role of PRP, it looks promising in protecting gonad during chemotherapy that should be elucidated further. Thank you very much for your kind attention.
Thank you, Dr. Biweko. Our next speaker is John Rio Lee from